morning, distinguished professor, respected elders, and ladies and gentlemen. On behalf of Heteroless Limited Myanmar, it's my great pleasure to warmly welcome you all to today's scientific symposium on current approach to heart failure management. We are honored by your presence and sincerely appreciate the valuable time you took to join us today. Please allow me to introduce myself. My name is Itanawe, Assistant Product Manager at Heteroless Limited Myanmar. Today, I will be the bestseller ceremony for today's scientific program. May I kindly request all the participants to take their seat as our scientific program will begin shortly. Thank you. May I kindly request all the participants to take their seat as the program will begin shortly. Thank you. မကြမီချိန်ကလေးမှာအခမ်းအနားစတင်တော့မှာဖြစ်တဲ့အတွက်ကြွရောက်လာကြသောဆရာနဲ့ဆရာမများအားလုံးကိုနေရာယူပေးကြပါရန်အတွက်လေးစားစွာဖိတ်ခေါ်အပ်ပါတယ်ရှင် Today, we are going to hold this program with 10 key agendas. May I briefly outline the agendas before we start? Agenda 1, introduction speech by our country manager, Mr. Babesh Bahila. Agenda 2, opening speech by Professor Lynn Aung. Agenda 3, scientific session on fine-tuning heart failure management, practicable strategies to practical problems by Dr. Don Robespierre C. Agenda 4, scientific session 2 on circulatory and bed surgeon in clinical practice. A case-based deep dive by Dr. Praveen B. Power. Agenda 5, official inauguration or sequence by all participants. Agenda 6, product presentation by product executive Ms. Winsu Mo. Agenda 7, Q&A session. Agenda 8, lucky draw session. Agenda 9, closing remarks by Professor Zolian. The last agenda, Agenda 10, is our country manager, Mr. Baba Vila, where we given our thanks. Good morning once again to our honorable chairperson, respected speaker, and distinguished guests. Heart failure continues to be one of the most complex cardiovascular conditions requiring timely and evidence-based intervention. Today's meeting aims to share practicable clinical perspectives and strategic approach for improving patient outcomes. This scientific program is proudly organized by our Hetero Labs Limited Myanmar. To officially begin the program, may I respectfully invite our country manager, Mr. Babesh, from Hetero Myanmar to deliver the introduction speech.
So, Minglaba, hello, Minglaba. Good morning, everyone. Good morning, respected Chairperson, Professor Aung, our distinguished speaker, Dr. Don and Dr. Praveen, our respected all participant doctors, healthcare professional, and dear colleagues of Hetero. On behalf of Hetero Labs Limited, it is my privilege and great honor to welcome all of you to the today's scientific session on the current approaches in heart failure management. First of all, I would like to sincerely thank all of you for joining you despite your busy schedules, and your presence today reflects the continuous dedication of Myanmar's medical community toward advancing cardiovascular care and improving patient outcomes. Doctors, cardiovascular disease is no longer only a global concern, as you know that. It is becoming an increasingly serious healthcare burden in Myanmar as well. So according to World Health Observatory, Myanmar recorded more than 152,000 cardiovascular related deaths in 2021 alone, placing the country among the higher cardiovascular mortality burden nations globally. The age standardized cardiovascular mortality rate in Myanmar is reported at approximately 364 deaths per 100,000 population. In addition, WHO and regional health data indicate that non-communicable diseases now account for nearly 75% of total deaths in Myanmar, with IHD and stroke ranking among the leading cause of mortality. One of the major drivers behind this burden is hypertension. Recent Myanmar studies have shown that hypertension prevalence ranging for nearly 39% to over 50% among adults, especially in population above 40 years of age. A published cardiovascular morbidity study from Myanmar further reported possible heart attack prevalence of 7.5% and heart failure prevalence of 2.8%. Angina prevalence is approximately 9% among adults studied in Lower Myanmar. So this is exactly why the scientific platforms like today's symposium are so valuable, and they will allow us to exchange our knowledge together and together help patients for heart failure management and heart failure treatment. So we are truly honored to have highly respected national and international faculty with us today who will share their expertise and clinical experience in this important therapy area. Once again, I extend my heartfelt gratitude to all of you, and I wish everyone have a highly productive and meaningful, successful scientific session ahead. With this, thank you, welcome once again, and with this, I would like to hand over this session to Professor. Professor, please. Thank you very much.
Thank you very much for the introduction, sir. Now it's our great honor to invite our respected chairperson, Professor Aung. May I kindly request everyone to give our professor with a round of applause.
Good morning, ladies and gentlemen. You all are welcome to this scientific meeting, and I'm really honored and glad to be chairing these sessions. Today, as Master of Ceremony said, there will be two renowned speakers. One is from Philippines, Dr. Don Reyes, and then another one is Dr. Praveen from India. Originally India, I will introduce later, why I said originally, And as you all know, this topic is very common problems faced by the general practitioners, family physicians, general physicians, as well as cardiologists. Not only cardiologists is managing this problem, but also by the other healthcare providers, because huge problems of the heart failure. More than 65 million people has been suffering from the heart failure worldwide. That means a lot number, more than our populations. Our population is around 53 millions, and globally 65 millions. That means a lot of people has been suffering from the heart failure. In such case, just remind the history of the congestive heart failure. When I try to recall my history, when I was attending the medical school, the classification of the heart failure is very simple. Right-sided heart failure, left-sided heart failure. If they combine together, we call it a congestive heart failure. Again, The causes of the heart failure, when we recall, right-sided mainly by the COPD, asthma, and pulmonary valvular and tricuspid valvular diseases, and some of the cardiomyopathies. Again, for the left-sided heart failure, common cause is ischemic heart, hypertension, cardiomyopathies, and in our countries, like tropical countries, we have been seeing many cases with the multivalvular rheumatic heart diseases. And in the history, around 1930, classification of the heart failure is like that, right, left heart failure. And then functional classification, again, if you have ever heard about the NYHA classification according to the performance of the patients, 1, 2, 3, 4. That was started in around 1930, and it became modified around 1960 and 1990. That's a long, long time ago, And then after that, around 2001, the stages of the heart failure has been mentioned by the different society all over the globe, like a stage A, B, C, and D, according to the structural disease, according to the functional, performance, and then appearance of the symptoms. They classified like A, B, C, D. But started around 2013. We changed the classification according to the left ventricular ejection fraction by the echocardiogram. You now know well about the classification, updated classification, very clearly that there is a heart failure of the reduced ejection fraction when the LV ejection fraction is less than 40%. If it's between 40 to 50%, it became moderately reserved ejection fraction with the heart failure, and preserved ejection fraction, that means ejection fraction is more than 50%. This is a well-known accepted classification nowadays because treatment strategies depends upon such classifications. You will remember that around 2022 and 2023, ECC, AHA, and ESC adopted the very updated guidelines comprising 4 pillars. 4 pillars is now, well-known strategies in the management of the heart failure. What are these 4 pillars? You know well that ACE inhibitors or ARB or ANI, okay? And then another one is the beta blockers. Some of the beta blockers, not all the beta blockers. And that one is a mineralocorticoid receptor antagonist, and finally SGLT2 receptors, antagonists recently. All right. These 4 pillars are now well known. And then this is a current, specific treatment for the heart failure, especially reduced ejection fraction, also known as HFrEF. Today, 2 speakers will be highlighting current approaches in the management of the heart failure in those areas. But treatment is, every treatment we have been facing challenges and the limitations according to the country situations, especially developing countries, developed countries, countries having the rich, resources and then limited resources. They will be discussing the problems facing in those areas of the management. And now, first speaker, Dr. Don Reyes. I think my pronunciation is okay. All right. Okay. Let me introduce first to the first speaker to all of you. Dr. Reyes is an internist and cardiologist with extensive training and board certification in the internal medicine and cardiology, including diplomate status from the Philippine College of Physicians and Philippine College of Cardiology. He specializes in adult cardiology and internal medicine, actively participating in the UST Hospital, Alabang Medical Clinic, and other medical centers. He completed primary and secondary education in Cagayan Valley, graduating valedictorian. He earned a BS in physical therapy from the University of St. Thomas, then a Doctor of Medicine degree from the same university. His postgraduate training includes medical internship and internal medicine residency, and he completed adult cardiology training at UST Hospital and pursuing a master's in business administration. Dr. Reyes holds leadership positions such as chair of the Cardiopulmonary Resuscitation Council of the Philippine Heart Association, auditor for the Resuscitation Council of Asia, and editor-in-chief of the Philippine Heart Association publications. He served as head of the emergency services at UST Hospital and is involved in research committees and academic faculties at UST. He is a fellow of the Philippine College of Physicians, Philippine Heart Association, Philippine College of Cardiology, and member of the various medical organizations. Overall, Dr. Reyes is a highly qualified, active clinician, researcher, and leader in cardiology and internal medicine, contributing significantly to medical education, research, professional development in the Philippines. Now he's going to talk about the fine-tuning heart failure management, practicable strategies to practical problems. Shall welcome Dr. Don Yaris, please.
Thank you, Professor Aung, for that very humbling introduction. I always cringe whenever my CV is mentioned. I just would like to be known as the most handsome cardiologist from the Philippines. Give me a warm round of applause for being the most handsome. All right, so I would say, Mingla ba? All right, it's mabuhay in the Philippines. So today, it's my honor, it's a privilege on my part to be speaking before you. So I'm really excited because it's my first time in Myanmar. And today, speaking before you gives me that pressure to share with you not just my expertise, my little expertise, but my experience. And later on, we'll be sharing experiences, how we can improve the management of heart failure patients, not just in the world, but particularly in Myanmar. So do you have, I don't want to be behind the podium. Yeah, a microphone, please. All right. Hello. Where's the switch? This one. All right. Okay, I'd like to take the center stage because it's early in the morning. It's Sunday. I know this is not really the best time for us to learn something academic, but I'd like to be in front so that I'll be engaging. You just had breakfast. And I don't want to compete with your gastrointestinal circulation because we're going to do something cerebral from this on, okay? And forward. All right, so these are my disclosures. This is my university, the University of Santo Tomas, the oldest university in Asia and even older than Harvard. So, but I'm not that old. Professor Aung is. Okay, and just to keep you awake. So for today, we're going to talk through this one. I'll go briefly with the burden of heart failure, but largely we'll talk about practical problems, how we can solve them. I know we share a lot of commonalities because I'm from a developing country, not so different from you. We share the same problems. You agree? And hopefully we will be learning from each other, all right? And let's talk about the burden of heart failure. Professor Aung has mentioned that, globally it's about 65 million suffering from heart failure. And it's the #1 cause of hospitalization for people 65 years and older. But mind you, we're seeing younger and younger patients suffering from heart failure. In my case, like probably the professor, we're seeing heart failure patients whose age is 20 or 30s, right? From different causes. It's not just ischemic anymore. And there are a lot of causes causing now your heart failure. And I see young people here. Today, probably we're seeing 65 million cases of heart failure. By 2025, when all of your speakers here, professors here are gone, you'll be the ones handling heart failure cases, you'll be seeing more. So if you don't want to see anything more, then you have to do something significant now, so we could curb down the rates. And at 5 years, 1 out of 2 with heart failure patients would die. And every time a patient gets hospitalized for heart failure, the prognosis worsens, okay? If you take a look into this graph on the right side, every time a heart failure patient goes into the hospital for acute decompensation, the cardiac function worsens. And each time the cardiac function worsens, the prognosis becomes worse, shortening the lifespan. And we have to do something about this. In a Canadian study, they found out that if a patient had admissions for acute decompensation for 3 times a year after that, half of them would have died. So you don't want your patients to be hospitalized every so often, because that's going to spell out a poor prognosis, shortened lifespan. Okay? Now, if you take a look into those patients with heart failure who gets hospitalized versus those who don't get hospitalized, who gets to live longer? Even if you have heart failure, if you don't get hospitalized, you get to live maybe 3 years longer compared to heart failure patients who get hospitalized. That means to say, one of the main goals in managing heart failure would be to decrease or to prevent hospitalization or rehospitalization, because definitely that's going to worsen the prognosis. And in my country, these are the numbers. About 16 cases for every 1,000 Filipinos, they are admitted because of heart failure. And they would say about a week in the hospital, and we would spend around 1.8, almost 2 billion pesos just for this problem. And if we now take a look into the death rates, we're higher than other Asian counterparts or even to the rest of the world. I don't know what we're doing wrong. We can blame a lot of things, right? We can blame the government, we can blame the patient, but we have to do something as doctors, right? So that's our primordial obligation as physicians. Now, as we can see here from this data, I don't know if it's kind of clear to you guys, you can see here in the Asian region, Taiwan is the leading in terms of the primary outcome of both deaths due to heart failure and hospitalization due to heart failure. But look at, we don't have Myanmar here, but we have Southeast Asian countries like Thailand. We have there, of course, the Philippines when it comes to death due to heart failure and death due to any causes. My country would be leading, and I'm not proud of that. And I'm sure we have similar numbers. Do you agree? I guess so, right? Now, when we talk about heart failure, we just don't talk about death. We just don't talk about the quantity of life. We also talk about the quality of life. And these are things that we doctors often neglect because we are kind of focused on the numbers. What's the blood pressure? What's the lipid? What are the medications? What is the cost of these medications? But behind this, the concerns of patients would be non-mortality, but the morbidity. Let's say about 2/3 of patients with heart failure would have problems with mobility. They can't really move around from the bed to the bathroom. Going up to the 2nd floor, there would be difficulties. And about 3/4 of patients, 3 out of 4, would have problems in carrying out the usual activities, like maybe sweeping the floor, you know, the usual Asian patient would do. Take care of the grandson or the granddaughter, right? Going to the market, doing laundry and all those things, they can do that. And that would negatively impact on the quality of life. More so, self-care, dressing up, going to the bathroom, taking a bath, cleaning yourself. That's going to be a big problem in about 1/4 of cases. And the most, I think, neglected area of concern of patients with heart failure would be mental health. 1 out of 2 would have some mental issues like anxiety or depression. As physicians, do we get the time to evaluate these mental health issues? I know there's a lot of things expected of us. Like, I know in Myanmar, there are only 90 cardiologists. And most of you here are non-cardiologists, so they need your help. They can't take care of the 54, 55 million Burmese having heart failure or other form of cardiovascular disease. That's why we thank companies like Hetero for gathering us here to gain more insights and knowledge how to treat our heart patients. So for that, let's thank them. And of course, they're promoting a product. Okay? Now, let's go to the principles of managing heart failure. We have just 3. Let's just simplify it. Number 1, we would like to increase longevity. We would like to increase the quantity of life. Number 2, we would like to prevent hospitalization due to acute decompensation or exacerbation of your heart failure. And number 3, from the patient's point of view, more importantly for patients, not really for us, would be the quality of life. They would have symptom relief. They would have improvement in functional capacity that they can live their lives happily, even if they have some heart problems. Is that right? That's a premium among Asians, being with family. Am I right? To be with family is more important. Live it as though it were your last day, even if you die tomorrow, right? That's so fatalistic, that's so Asian, all right? Now, let's go to some clinical practice guidelines. We're lucky in our lifetime that we, present doctors, have 4 miracle drugs. I would say miracle drugs. So, Professor Aung has been mentioning about history. I'll mention something about history too for the younger generation here. Who are the Gen Z here? Gen Z doctors? We are the Gen Z. Millennials? Who are the millennials? Boomers? All right? But we are lucky we have 4 magic drugs, wonderful drugs. We call them the 4 foundational pillars of heart failure management. You have your ACE inhibitors, your ARBs, your RAAS inhibitors, renin-angiotensin aldosine inhibitor drugs. We can include the ARNI in there. But this was introduced in the late 80s, the early 90s. The big time then was, Professor, it's enalapril, right? It was enalapril that was the star for heart failure management. And then few years later, when beta blockers were deemed contraindicated against heart failure, it became another star. Beta blockers that include your metoprolol succinate, not the tartrate, bisoprolol, your carvedilol, and of course, not included, but it can be used for heart failure management, your nebivolol. So these were introduced beginning in the late 90s to 2000. Then came the MRAs in the 90s. Your spironolactone, and now you have your plerinone, and now you have the non-steroidal, your finerenone. We have wonderful drugs in our lifetime. And most recently, you have your SGLT2 inhibitors, your dapagliflozin, empagliflozin. But before this, in 2014, your ARNI was introduced as a magic drug, as a magic pill for heart failure. That was in 2014. Now, if we take a review of what has been established in the past decades, we found out then in the late 80s to 90s that using enalapril, other ACE inhibitors, and other ARBs, by the way, there are only 3 ARBs that are found to be beneficial for heart failure. You have your valsartan, you have your candesartan, and you have your losartan, all right? Now, if you now take a look into the risk reduction in terms of death, hospitalization for heart failure, there seems to be a 10 to 15% decrease in these outcomes using your enalapril. That time, it was very, very good. Because at that time, when you had heart failure, it was just a downhill, steep course. Everybody that time would die sooner or later. But with the introduction of the RAS inhibitors, it proved something good. And then we had the beta blockers. So far, they have the biggest impact on cardiovascular mortality and morbidity in patients with heart failure. They bring about around 35% risk reduction. That's why beta blockers are now a mainstay in heart failure management, where in the past decades, they were contraindicated, but now they're the big stars. And we had the MRAs. They would bring about 30% risk reduction. And of course, with the introduction of the ARNI in 2014 through the Paradigm Heart Failure Trial, we found out that even though ACE inhibitors and ARBs were very effective, giving your ARNI doubles the benefit. I'm not saying that ACE inhibitors and ARBs are no longer effective. It's just that ARNI does it better. And if there is something better that we can offer patients, why not give it to them? And Myanmar is very lucky. You don't have strict rules about patency of drugs. You have a lot of drugs here. I envy you. In the Philippines, it's very strict. I plan of getting more drugs here so I can bring them to the Philippines, if that can be, if I can pass through the borders. All right? Now, in 2021, the Europeans came up with their guidelines, all right? And they recommend that we have to use these 4 foundational pillars. Plus, of course, the use of your loop diuretics, your furosemide. Remember, furosemide is just used for symptom relief, to diurese your patients, to squeeze out the extra water if they need it, right? But they don't confer any additional benefit on mortality. Remember that. It's just the 4 foundational drugs that have been found to confer some benefit on mortality and morbidity. And when managing heart failure with reduced ejection fraction, one of the killers among these patients would be sudden cardiac death due to fatal arrhythmias. Who are these patients who would be suffering from that? Those who have ejection fraction less than 35%. And as the ejection fraction decreases, the chances for suffering from sudden cardiac death from fatal arrhythmias would be higher. So the lower your EF, the more dangerous it is. That's why if you don't get to improve the ejection fraction, you might want to consider an ICD. I know it's expensive. For countries, developing countries like us, and out-of-the-pocket expenses for hospitalization and other management, that would be difficult, right? Now, you have to look also into the QRS. I hope the cardiologist here would teach you how to read ECGs, your EKGs. If the QRS is wide, you might need a defibrillator. That's why you might need a CRT, cardiac resynchronization therapy with defibrillation. Then that would be a wise step. But again, it's going to be costly. I know it's just nice to discuss about this, but it's going to be costly. I know that. I feel you. I can relate with you guys. But, you know, if they're just okay, 35%, and they're not symptomatic, probably you're good with just medications. That's what we hope for, right? Hopefully they're just simple heart failure patients. All right. Now, 2 years later in 2023, of course, they looked into managing other forms or phenotypes of heart failure. Of course, when say reduced ejection fraction, the ejection fraction is less than 40. If it's heart failure with mid-range ejection fraction, the ejection fraction would range from 41 to 49. And if it's preserved, it would be at least 50%. Then again, the natural course of these different types of heart failure would be different. They would behave differently with HFrEF. So the management would also be different and quite confusing. But from the Europeans, they have prescribed, they have recommended dapagliflozin, empagliflozin would still be a class 1 drug in the management of your HFmrEF and HFpEF. The use of RNE, your ACE inhibitors and the ARBs included, they're considered class 2B for HFmrEF. So ejection fraction 41, 49, you can use them. Your MRA, your spironolactone, your eplerenone, they can be used. And now included is your finerenone. It's already considered with MREF and HFpEF, and beta blockers, class 2B. But when your patient is classified as HFpEF, you can only use empagliflozin and dapagliflozin. The magic of ARNI and the other foundational drugs seem to get lost. But probably you have to treat all other comorbidities. If they have blood pressure problems, then you can give probably your beta blockers. If their heart rates are high, maybe a beta blocker may too. Or another ACE or ARB may help your patients. So treat all other comorbidities accordingly, all right? Let's go to the American side, to North America. So what did they say? Similar to the Europeans. But they quite emphasize that you have to start all 4 drugs soon or very soon. Which to go first, which to start first, they didn't specify. But we'll talk about that in a while. Which drugs to start first. And again, the stars would be your ARNI, your beta blocker, your MRA, and your SGLT2 inhibitors. Very similar to the Europeans. Now, ARNI, in this treatment of your heart failure with reduced ejection fraction, stage C, that means to say there's structural problem in the heart, there are symptoms of heart failure either currently or in the past, you'd classify them as class C. ARNI and the other foundational therapies for heart failure are the mainstay. And we can use, of course, your ACE inhibitors and the ARBs if your patients cannot tolerate, if there are contraindications to the use of ARNI. Again, if you don't get to manage your heart failure with these 4 foundational drugs, there are next tier medications. Like you can use a diuretic if you just can't squeeze the water out of the heart. You can use hydralazine, isosorbide dinitrate if your patient is resistant to the drugs and there are some racial issues like being African American. And you can use ivabradine if your patient has high heart rate as long as they are in sinus rhythm, right? Because ivabradine has also been found out to be beneficial in heart failure patients. And If you still cannot improve, you probably Versiguat, which is not readily available here in this part of the world. Probably there's benefit. But for me, I don't have experience yet because this is not available in the Philippines yet, in developing countries like us. All right? Now, what is the tenet? What is the mandate now for us doctors managing heart failure? We have to start all 4 foundational therapies early. Do not wait. Do not delay. Because any delay in the initiation of these 4 foundational therapies, you will miss the opportunity of saving a life or preventing the complications. All right? If you start them early, studies have found out that tolerance would be better along the way. And again, it is always better to prevent the complications from happening. It is always better to start early and prevent the complications, because when the complications set in, that would be more challenging. That would be more difficult to treat. All right? So at the beginning, be aggressive. And the use of SGLT2 inhibitors together with ARNI, if you choose these 2 together at the early onset, it has been found out that they are better tolerated in the long run. And I would say they would enable the tolerance of the other drugs like your MRA and beta blockers, because these 2 drugs in combination, they would prepare the body, not just the heart, to tolerate the other drugs needed to treat a heart failure patient. All right? Now, what is the benefit if we start all 4 drugs in one patient? As you can see here from a large registry in the UK, in patients who were treated traditionally or conservatively, they would have a lot of events. But in patients who receive all 4 drugs early on, there would be no acute events or no hospitalization due to heart failure in the next 8 years. Just imagine that. 8 years free from being hospitalized. You save a lot of money. You promote quality time with family. See how much that would matter to your patients who have families waiting for them at home. All right? Now let's go to the benefits of ARNI in heart failure patients. Let's just discuss the most landmark trial. It's called the Paradigm Heart Failure. This was done in around before 2014, and it was compared to enalapril. That time, enalapril was the big star. Okay, it was the best for heart failure at the time, and they tried to compare ARNI with enalapril. So what did they find out? Combined together, CV death and hospitalization, there was a 20% decrease. ARNI was better. Okay? In terms of CV death, again, ARNI was better compared to enalapril. There was a decrease in the events of death by about 20%. And if we talk about all-cause mortality, that's due to any cause, not just heart failure and just as a heart, there was about 16 to 20% decrease in this area. Now, how about hospitalization due to heart failure? There's about 20-21% decrease, and ARNI did better again compared to enalapril. I know that enalapril is cheaper. It's more readily available. But if you could offer something that's better, and it could significantly transform the lives of your patients, why not give ARNI? All right? To summarize, if you can just see this one, your primary endpoint, 20% decrease. ARNI was better. Cardiovascular death, ARNI was better. In terms of hospitalization for heart failure, ARNI was better. Now, we talk about quality of life as measured by the KCCQ, Kansas City Cardiomyopathy Questionnaire. They measured physical activity, symptoms, and also mental health issues. ARNI did better compared to enalapril. In terms of atrial fibrillation onset, it was a tie. ARNI was not better compared to enalapril, or ARNI was nothing worse than enalapril. So it's a tie, all right? In terms of renal decline, it's a tie, because that's an issue when we use RAS inhibitors, right? I think Burmese doctors are quite very conscious about potassium. We'll talk about that later, all right? Now, if we summarize now trials using ARNI, both from Paragon and the Paradigm Heart Failure, there is a significant improvement in the quality of life. Again, for me, when I see patients, I see more from the patient's perspective. What is it for them? To be relieved of the symptom, to be going to the market or carrying their grandchild. That would be of utmost importance for me. even if their lifespan is shortened, because definitely if your patients have heart failure, their lives would be definitely shortened. But at least before they die happy, right? All right. Now, let's go to some challenges that we encounter from day to day. All right. Number one, what should we start the patient on? Will it be ARNI? Would it be beta blocker, MRA? So what? Now, traditionally, it was thought that you would do this step by step. You don't add a drug until you up-titrate the drug to the maximum dose that was achieved in the clinical trials. And this has a lot of wrong presumptions or assumptions. They said that you start with your ACE inhibitors because they were discovered first. All right? That's a wrong assumption. Remember that the trials that included all of these ones, there were no 4 foundational therapies present. Not until the SGLT2 trials came about. Even when ARNI was introduced into the market, there was no SGLT2. And delaying the introduction of all these 4 would cause a delay in the reaping or the achieving the benefits conferred by all of these 4 drugs combined together. And if you now follow that traditional style of up-titrating or adding on the drugs, it would take about 6 months, right? Let's not wait for the drug to be up-titrated to maximal doses. The current strategy is put in everything as long as the patient can tolerate. So probably one proposal is that we can start with a beta blocker combined with an SGLT2. The beta blocker, either in a bivalol, carvedilol, bisoprolol, or metoprolol succinate, you can start with low doses, half doses, or even 1/4 doses. That's the way they started their experimentations, the clinical trials in the past. They start with low doses, then they slowly up-titrate. Then combine with it in SGLT2. No problem with SGLT2 because it doesn't really affect your blood pressure. If it does minimally, like about 3 millimeters mercury from the systolic blood pressure. So it doesn't really matter, all right? Then you give in your ARNI, maybe a week or 2. Then you probably would start with half dose of 50 milligrams. And if your patient's BP is allowing, you can give the 50, then titrate to 100, and then you give the MRA. Now, this combination tells us now, gives us the opportunity for patients to tolerate the other drugs, like the MRA. You know that MRAs can also increase your potassium, right? And can also compromise renal function. But then again, by starting your SGLT2 and with ARNI early on, you could prevent that. Further renal decline. We all know, you've heard a lot of lectures about SGLT2. They protect the kidney too. Not just the heart, not just for sugar, but for the kidney too, right? Now, these are the proposed rapid sequencing strategies. The term, rapid. How rapid is rapid? 4 weeks or so. Don't wait for 6 months. 4 weeks, all right? So one strategy is based on hypothetical pharmacological synergies. I'm going to be telling you one partnership later on, one combination. And for me, I am on clinical profiling of patients. Depends on the clinical profile. If the BP permits, probably I can start with ARNI right away. If the BP is quite, borderline, then probably low-dose beta blockers. But SGLT2 will always be an initial preference. Right? And again, by extrapolation from a lot of studies, there is a recommendation based on mathematical modeling. Now, this one, if you would like to start your drugs, 4 foundational drugs within 4 weeks, all right, you can start with a beta blocker in SGLT2 for the reasons I've mentioned earlier. Low-dose beta blocker plus SGLT2. A week or 2 after, you can start your ARNI. A week or 2 later, then probably the MRA. Spironolactone, don't get worried so much about 25 milligrams of spironolactone. It doesn't really affect your blood pressure. It doesn't really affect your renal function. But of course, we should take a look into the renal function, right? So don't be afraid. Just monitor your patients closely. That's just the other side of it. You have to be in frequent connection with your patient when putting all these drugs, okay? This is a mathematical modeling based from 6 large trials on heart failure. As you can see on the screen, there are numbers in the colored, what do you call that? Those horizontal bars, right? Now, the number tells us the number of weeks that we up-titrate the drug. And as you can see, Okay, where's that? Event reduction is here. If it takes you too long, again, this is a too long a strategy, you would still get a benefit at 22.8%, but if you do it shortly, like a lot shorter, it would translate to about 47.3 risk reduction. Compared to 22, 47, what's your strategy? Faster or slower? It's going to be faster, right? Your patient might die from a fatal cardiac arrhythmia if you just don't do this, right? In terms of all-cause death, again, the shorter, the better. From 7.4 risk reduction to about 13.7 with rapid up-titration. But which drug do we start with? From this mathematical modeling, it appears that the best combination would be this blue and, what color is this? Light blue. I'm poor with colors, sorry. It's not my my expertise, colors. So then again, you would like to use an SGLT2 and probably an MRA. But that's from mathematical modeling. Again, these are just expert opinion based on some mathematical modeling. All right. Now, but this is one concept too that is really interesting. If you combine now your SGLT2 and your ARB or your ARNI in particular, the chances for having hyperkalemia would be decreased. There is a physiological explanation to that. Your SGLT2 will bring in a lot of sugar and fluid flowing into the proximal convoluted tubule to the distal. Now I'm getting boring, right? You don't want academic lessons Sunday morning, right? But the shortcut of it is that with the excretion of a lot of fluids, there's going to be an osmotic diuresis that's going to prevent the reabsorption of potassium, right? So less potassium is going to be reabsorbed, more potassium will be excreted. Again, downplaying the risk for hyperkalemia if you start combining your SGLT2 and ARNI early on, all right? If you want to be so academic, search Google, okay? All right, let's now go to number 2 challenge, acute heart failure. Question is, in patients admitted for acute heart failure, either for the first time or decompensation, can you start your ARNI right away or your drugs right away? Let's see the recommendations, all right? In patients with HFrEF requiring hospitalization, pre-existing GDMT or 4 foundational drugs should be continued. Do not discontinue unless there is a clear contraindication. Let's say there's a significant renal decline or there's significant hyperkalemia. All right? Those are the things. But if they're on drugs, they get readmitted for acute decompensation, maintain all 4. Unless contraindicated. Another recommendation is, if your patients experience mild decrease of renal function, or there's a drop in blood pressure, but they are asymptomatic, continue the drugs. But the question is, what is a mild decrease? You only discontinue your drugs that affect the kidney if the renal decline is about 30%. For some, it's 20%. Some literature, some recommendations have it at 30%, but for me, I stay in the middle. 25%, right? Some say it's 20, some say it's 30. I say in the middle, it's 25, right? So we should not discontinue. And if you need to discontinue, always try to reintroduce again the drugs when the problem gets resolved. So what am I saying? As long as they can be on these drugs are forever. Forever, all right? Another recommendation. In patients with HFrEF, GDMT should be initiated during hospitalization after you achieve clinical stability. So if it's their first time to be having heart failure, start as soon as you can before discharge and up-titrate rapidly, all right? Again, in patients with HFrEF, discontinuation of GDMT is necessary during hospitalization. It should always be reintroduced whenever they become stable. That's the rule. So some drugs are meant to be forever. All right, let's continue. So this is the evidence from the Pioneer Heart Failure Study. So it compared again ARNI versus enalapril. So what did they find out? Again, there was a better decrease in your NT-proBNP. You know, everybody knows NT-proBNP. It's a marker for heart failure. It spells prognosis. It spells improvement, right? So there was better improvement with ARNI compared to enalapril. And in terms of renal function, there was less renal function with ARNI. And rehospitalization, there were less rehospitalization with patients on ARNI. All right? So if you now talk about initiating drugs, we learn from the strong heart failure, but that if you put all drugs together, there is a big 34% reduction in death and hospital failure readmission. Because if one gets hospitalized, again, I am always repeating this one, it means there's increased risk. So the opportunity for us is to initiate these drugs when the patient gets admitted, and upon stabilization, we should start the drugs, all right? Because if you don't get to start these drugs, that will spell some problems later on, sooner or later, okay? Now, how do we say if this patient is stable? We have parameters. Look at the BP. Is the BP at least 100? For me, sometimes I'm brave, 90 is stable for me. As long as the patient has no symptoms pertaining to low perfusion or poor perfusion. Again, you're not using IV diuretics for at least 24 hours. No diuretics, all right? No use of IV dilators, no use of IV inotropes, and renal function is stable, even if it's compromised, as long as it's stable. So sometimes we need nephrologists, but if you don't have nephrologists, then you should manage. That's a problem of primary care, if you don't have specialists around, right? And again, the serum potassium is important, maybe 5.1, it's safe for you to start. Below that, it's below 5.5, probably you can be brave, you can monitor it, but above 5.5, you have to bring it down first. Look for reasons why your patients are having hyperkalemia. And of course, there is no plan of using Dr. Praveen's skills of angiography because he's going to use dye. And if the answer is no, the patient's not stable, then solve the problem first. But if yes to all of this, then your patient is stable, then you can start initiating your 4 pillars of management. So start at the lowest dose. You choose any from the 3 proposals I've mentioned. But for me, my favorite would be an SGLT2 and probably a beta blocker. And sometimes I add on right away your ARNI if the blood pressure permits. And if the metabolic profile for a patient is safe, like potassium is okay, right? So I'm quite aggressive because I don't want to be seeing patients coming back to the hospital for readmission or due to some heart complications, right? And then you discharge the patient. Then you follow up the patient. Then hopefully in the next 4 weeks, you can put all drugs, even if they're all in the low doses, right? What is important, you have all 4, regardless of the dose, all right? Then, of course, if you still can't manage the heart failure symptoms, then probably you can go to the second liners, like looking into iron deficiency. So that's another problem, right? For a primary care physician, you need a hematologist. But then again, if you don't have a hematologist, then you have to learn on your own again as primary care physicians. That's why I admire you guys here in Myanmar, because you as general practitioners or primary care physicians, you just cannot rely on specialists because there are not a lot. So you have to learn on your own, right? Then you may use your iron supplementation, your Vericiguat, which is really hard to come by, your Ivabradine, it's easy, it's in the market, and of course, device therapy, like ICD or CRT-D, all right? So this is a strategy. If your patient has been admitted, and if you can put on your ACE inhibitor, your ARB, or even your ARNI, then you can, as long as the conditions permit. And then as they're nearing euvolemic phase, they're getting stable, I would try on my low-dose beta blockers, all right? Low dose, right? And then as the days go on, I would put on the MRA, again, checking on sodium, potassium, and everything. And then probably before discharge, I could put on my SGLT2. In my practice, not really following the guidelines, maybe 2-3 days interval, checking on these parameters. So that before they get discharged, I have all 4s on this patient. They're in the hospital, so don't worry. You can monitor them, right? They're not at home. They're just nearby. So you can monitor, right? And then at discharge, on follow-up at the OPD, then you can up-titrate the drugs. Start at low doses, up-titrate when they're out, all right? Again, the doses are their ideal doses. In the real world, no one has really achieved the top doses, even in trials. Maybe around 60%, the best that, these trials have achieved the targeted doses. But what is important is these patients are on the necessary drugs. It's only MRA, your spironolactone, and probably Plerinone that has the highest compliance among doctors and patients, right? But the others, we don't in the real world, right? So these are the different recommendations when you use the other 4 foundational drugs. Your beta blockers, you can always start at low doses, then you slowly up titrate until the patient can tolerate it, okay? Maximally tolerated doses, all right? And again, these are the confusion or the dilemma. If you give half dose, you just get the half of the benefit. It's wrong, because in trials, even at low doses, we get to see the benefit. Actually, most of the benefit are accrued in the beginning of the trials, when the doses are still low. And the benefits would be seen early, all right? They would be seen in the first 2 weeks to 4 weeks, even if you have not even achieved the full doses. And if you add more drug, of course, more doses, that would mean more benefit. But actually, studies have shown that if you up titrate the dose, the additional benefit is just modest. It's not really like it's going to double up. No. So the lesson is at low doses, early on, we can reap the benefits. Again, lessons from the strong heart failure trial. It was shown that rapid initiation, putting all 4s early on in the treatment, then up titrating quite fast, as long as the patient can tolerate, then we can see the benefits. All right. So in terms of target versus benefit, in terms of survival, most survival benefit is gained at the starting dose. I've mentioned that. In terms of hospitalization, you see additional benefit if you up titrate the dose, but the additional benefit is modest. But there's still some benefit. And in terms of sequencing, comprehensive low-dose therapy. Whatever is suitable for your patient, as long as you have all 4s, that's going to spell some magic for your patient. Challenge number 4, how do you monitor treatment response? Now, NT-proBNP is a nice thing. It's recommended that you monitor, you measure NT-proBNP on admission and before discharge. So when's the next? Maybe 2 weeks, 3 weeks, as long as you see some symptom improvement or worsening, then it's okay to monitor NT-proBNP. How about 2D echo? The guidelines are somewhat divergent, maybe after 3 months, because it's quite expensive and it's not easy to get it, especially in far-flung areas, all right? In centers, probably it's easy to get it, but we should develop our own policies and protocols for this one, right? How about side effects and complication? Hypotension, assess volume status and diuretic dose. I know I've learned from yesterday that it's a common practice to combine furosemide and potassium. If giving too much furosemide, you can just deplete the patient of volume, and that can contribute to hypotension. And then you check on the other drugs that bring down the BP. CCBs, they're good to bring down the BP. They're good to protect the brain from stroke, but they don't confer any additional cardiovascular benefit. So probably the CCBs can go, right? And you can space giving the medications. Morning, mid-morning, midday, you know, but it's going to be toxic for the patient because there will be a lot of times that the patient will be taking medications. And most of the time, our patients with heart failure, they are on polypharmacy, right? So if you can combine drugs, that would be best, but again, at low doses. Declining eGFR, again, don't be worried. There is always a decline in renal function with the use of RAS inhibitors. If they don't decline, it is a proof that your drug is not working. All right? Sometimes it's a proof, oh, the renal function is declining. Oh, my ARB is working, my ARN is working, as long as it doesn't go below or above 30%. But for me, my magic number is 25, midway, between 20 and 30. And hyperkalemia, you check for the reasons why the patient is in hyperkalemia, right? Fruits, vegetables that are rich in potassium, and then you can always treat your potassium binders, but how do we go about it? Potassium, more than 6, stop the drugs that cause hyperkalemia. All right? 5 to 6, 5.5 to 5.9 probably reduce the dose. Correct the potassium and then check for reasons why the patient has hyperkalemia. And probably below 5 to 5, then probably just have to monitor. All right? So that's a recommendation. All right, residual risk and the gap exists still. From trials, we have done great things with the previous drugs I've mentioned, but it's not perfect. But we've done a lot, right? There's a great reduction in cardiovascular death and hospitalization for heart failure. But there's still a big problem. So what do? Pray to God. Wait for some new technology, some new drugs, and probably we look for some correctable causes, then probably refer the patient to Dr. Praveen, check the coronaries. If you could improve on the coronaries, probably the heart function may improve. And probably let's go for other, like LVAD, that's very expensive. At least in the Philippines, we're doing it right now, but it will really cost millions, like 5 to 10 million pesos. Very expensive. And only the rich could afford it. But LVAD is now a destination therapy. Heart transplants, it's still impossible, right? Have you had transplants, heart transplants here? Not yet, right? So there's still, we are still left with some residual risks, and we're waiting for that. So to close my talk, my key takeaway notes: guidelines on heart failure management are clear, but the implementation can be so challenging. Depends on the social, political climate. But we have to personalize our approach. There's no one-size-fits-all thing, right? And beginning or starting our patients on quadruple therapy will just improve survival and the quality of life. And we should titrate fast in 4 weeks, as long as the patient can tolerate it, put all fours and start early. Because if we start early, we can stay ahead. And with that, I would say, Che Supa. Maraming salamat. Thank you.
Thank you very much for the insightful and excellent presentations.
Thank you very much, Dr. Don Reyes, for your excellent and very comprehensive presentation regarding the current approaches of heart failure, actually, in the practical situations, practicable strategies in clinical practice. Now, as we are going to do the Q&A session only after the second speaker, shall move to the second topic, which is going to be sacubitril and Vercetin in clinical practice, a case-based deep dive, which will be talked by the Dr. Praveen Powell. I need to introduce Dr. Praveen Powell to a certain extent. That means, as he has been working in the Myanmar for nearly 10 years. Actually, I have been working with the Praveen in Paline International Hospital for 4 years, and we played golf together. He is able to speak Myanmar language, even sometimes more than me. Because some of the patients, they are not aware that Dr. Praveen is originally, came from India, because he talked in Myanmar to those patients, and initially they thought, oh, this is Myanmar, who was brought in, he was Indian, but brought in Myanmar. But finally, some of the difficult words, he need to get some help from the, medical office. That means, he has been working here for 10 years, and he's quite familiar with the Myanmar, and Myanmar people also well known, Dr. Praveen Powell. But I need to introduce a little bit more. And he has finished, MBBS in 2001, and he obtained MD, Master of Medicine, in 2008 with Golden Award. And after that, he has finished DNB Cardiology National Board of Examinations in 2014. And he has been working in cardiology department of Paline International Hospital with a dynamic career of the 10 years with esteemed hospitals like also in Care Hospital, Hyderabad, and Paline Hospital, Myanmar, reflecting cross-cultural experience. He has successfully and independently performed over 2,000 cardiac procedures, including angiograms, angioplasties, permanent pacemakers with 99% success rate. Is also treating over 500 outpatients per month with Accord, TMT, and Holter in the department. He's expert in heart failure care, including mechanical circulatory support and contemporary management. also, he is extremely rich performing diagnostic procedures and executing planned mechanical and surgical treatment procedures. And he also published, many papers related to the cardiology. And now, may I invite Dr. Praveen to talk your topic, sacubitril and valsartan in conjunctivitis, a case-based deep dive. Because sometimes we have been reading a lot about the guidelines, which is very scientific and research-based. But we need to know some other things like a real-world evidence and real-world data, real-world events. He's going to highlight the case-based studies which he has been seeing in his practice. Shall we welcome Dr. Praveen Bowl, please?
Minglawa. Thank you very much, Prof, for giving this opportunity to present the talk today. I would really thank you for Myanmar Medical Association and all the professors and patients and all teachers for blessing me for last 10 years in Myanmar. It's a second home. I will say first home and second home is India. So, Dejitumare for all your support. Like Prof said, I can speak Burmese. Yes, definitely. I like one word, Mijima Patipada. Okay, so middle way. So that is a blessing. So whenever I am in the stress, so I follow this. And another word is nothing is permanent. Okay, so these are the two teachings I always tell to people that we should follow in our life. So thank you, Dr. Dong, for very beautiful and structured lecture. So I would like to go more in the case-based approach because it is a practical thing, what I had seen in last 5 years or 6 years about when the SGLT2 inhibitors and ARNI has been introduced in this world. And I think so we as a human being are really blessed in this era that we have such a beautiful medical treatment available all over the world. And the best invention of these decades is ARNI and the SGLT2 inhibitors. So as we know, this is with this I will start the my lecture on the case-based deep dive. So we will be covering the sessions on the non-ischemic cardiomyopathy, ischemic cardiomyopathy, blood pressure management, potassium management, and the evidence of the case-based and the case summary. So firstly, we should know what is the heart failure. So there was a discussion between Prof and me that how we, as if there is no echocardiogram, how can we identify the patient is having the heart failure? As Professor is a big fan of the clinical cardiology or clinical medicine. So just a few words as back to the clinical medicine. The symptoms, when the patient comes with short of breath or easily tired in the emergency, like mole, lanshaulo mole, peolale. So you just think two causes. So asthma shile or heart failure shile. So there are the two differences between the COPD and the heart failure. So one is PND and orthopnea. Okay, lelino mola shilelo, it is mostly from the heart failure. Okay, and then like sitting position, short of breath is mainly from the COPD cases or history of the smoker. So then and if the sound is there, su sound shilelo, it is from the asthma. Okay, so these two are the clinical. And then when you examine the patient, okay, so respiratory system, if there are bilateral creps, it is heart failure. Okay, and if it's rhonchi, then it is a COPD. Most thing we forgot is, I think so, I should insist, is the JVP, jugular venous pressure. Very easy. If the patient has the raised JVP or distended neck veins, the diagnosis is sure you are dealing with the heart failure. So you have echo or not there, you should give the diuretics. So symptomatic relief is the best thing. Okay, you cannot talk all these 4 pillars without giving the diuretics. If patient gets relief after that, we discuss about this, because euvolemia is one of the necessary prerequisite for all the heart failure treatment. Patient will come with you with a short of breath. So symptomatic benefit, early symptomatic benefit is most important. So you can achieve that by having the proper dose of IV diuretics like Lasix 40 mg, or you can give the 10 mg per hour infusion for 24 hours. Okay. If it is resistant, then there are some newer trials. You can use lazone, okay, that is a metazolone, or you can use the acetazolamide, just for the extra information. But Lasix will solve your most of the problem. Coming back to the heart failure, so classification, we know that there are mainly the 2 types of cardiomyopathies which we see in our routine life. It's a dilated cardiomyopathy, okay, and other things which we see are restrictive cardiomyopathy. Dilated cardiomyopathy, nalonchi yoga shile. So many patients come with that, maybe ischemic or non-ischemic. Okay. Second is like a restrictive cardiomyopathy, usually diagnosed on echo, but old age patient. So when they become old, they become the diastolic heart failure, and their chambers of the heart, like atrium, enlarged. So it is like a restrictive type of cardiomyopathy. So left ventricular size is normal, but the left atrium are dilated in them. Others are the hypertrophic cardiomyopathy, which are found in young. So rare, I will not talk about that. But so this we can, I said first is a clinical, and second thing is you can diagnose these by echocardiography, can differentiate between the most of the cardiomyopathies. Okay. Once you get the diagnosis on echocardiography, you need to have the general management principle. First is like a drug therapy, like what we are going to talk. Second, where there is a family screening and genetic screening which is used for the hypertrophic cardiomyopathy. Thirdly, we have to think about the long-term prevention of the sudden cardiac death. Okay, these are more prone. If there is a EF is less than 30%, we need to think about ICD, intracardiac defibrillators. Okay, so this is on the long run. So if patient said, I want all the things, so you should have in mind that, okay, he needs this. Okay. And fourth is the lifestyle, definitely what Dr. Dong talked about, that the lifestyle quality, how he need to maintain. So other things is the disease specific management. It depends upon the valvular heart disease. We have to treat with the TAVI or TAVR or mitral valve replacement. If the patient is having ischemic coronary artery disease, he can get the treatment with the angioplasty or the bypass surgery. Or if the patient is having the ARVD or other things, so there are some cardiomyopathies which are like iron deposit, or there are some ATTR cardiomyopathies. There are some specific drug which are for the genetic cardiomyopathy. That is the different topic. So let's go into this. So what you see here, if some 45-year male walking into your clinic with the symptoms of, he doesn't know anything, and suddenly he get the short of breath and bilateral pedal edema and cannot sleep well, and then he comes to your ED with the dyspnea class 3, so means which is associated with the PND and orthopnea. And when you do the ECG, you see there is a left bundle branch block, LBBB. It's a widening of the QRS. So in these cases, 50-50 chances they have the dilated cardiomyopathy. And sometimes 20/30 it may be normal. So if it is LBBB with SOB, you should think more on the side of heart failure as a clinical. So then the next step is the echocardiography. If you have the blood test NT-proBNP, which is the blood test, which will help you to guide as well as diagnose the treatment and also to monitor the treatment. NT-proBNP. Don't worry about the values. Values are different depending upon the laboratory. Okay, so just do the investigation. If it is raised, it is heart failure. Then this patient came with all these symptoms, and then what we evaluated is first clinically we diagnosis he's having the low EF of around 30% and mild MR, and he was in the heart failure. So further we evaluated by him with the coronary angiography, which was normal, and then this is what we are seeing is the cardiac MR, mitral cardiac MRI, where you can see the LV is dilated, and here you can see the thickness is preserved. So this is one of the very important thing. The thickness preserved and there is no scarring. See, therefore we said early starting of the GDMT is very important. So if it is scarred and thinned out, the results are not so good in the late stages. But if it is a preserved thickness, the results are definitely very good. So there is an incidence of 6 crores, means it is a 1%, 1 to 2% of our population is suffering from the dilated cardiomyopathy or the cardiomyopathy. So it is a huge incidence for the all country. And simply classifying the cardiomyopathy in terms of the ejection fraction is more than 50, 40 to 50, less than 40. Less than 40 is like a reduced ejection fraction, and more than 50 is a normal ejection fraction, and 40 to 50 is a mid-range or mild LV reduction fraction. So remember that one. So it is simple. Just for your thing, less than 40 is where we have to put all the 4 pillars of the therapy into the thing. So in these cases, we started as soon as the patient was admitted because of the short of breath, we did the diuresis of the patient by giving the Lasix infusion. So after that patient, on that day, he passes 5 liters of the urine. So once he get the euvolemia, we are under control that, okay, now he is little stable. Otherwise, patient is struggling for the breath and you cannot add everything. So sometimes on that day, we started him with the once day after the diuretics. Immediately next day, we started him on the ARNI. The beta blocker was slowly introduced. So all these things, all 4 drugs, we slowly introduced at the gap of the 2 days. And then we make him before the discharge, he get all the 4 drugs. So as Dr. Dong said, see, on the first day for the SGLT2 inhibitor, you don't need to take the blood pressure into consideration. So this is the very first drug you can add on the first day. On second, and at the same time, beta blockers. In these cases, nalongkhone meale. So you should just give the beta blocker, no problem. Previously, it was told that they are contraindicated in the acute heart failure. So it is not like that, okay? So you can use the beta blockers early in the disease, okay? Then as soon as the patient had a BP, these patients usually has the blood pressure on the lower side. Don't worry, if you can manage up to 90. So you introduce the low dose of ARNI to these patients. Half tablet is also okay. So 25 milligrams. So we need to add it. So go gradually. If you give 50 and patient go in hypotension, then you need to withdraw all the things. So gradually slow titration of this is very important. And because of you are giving diuretics, there will be hypokalemia, and the MRA are the best choice for adding, like we have the aldactone or iplerenone or finerenone. So all these 3 you can plan to add gradually in this patient. So it is very simple. So 4 pillars, ARNI, beta blocker, MRA and SGLT2 inhibitors. We all are aware of the DAPA and EMPA. Don't get confused about the dose. 10 mg of anyone is okay. Nothing to worry. MRA, we have the aldactone 25, eplerenone 25, and finerenone 10 and 20. So you can start with the aldactone 25, and depending upon the potassium levels you can manage. The side effect of aldactone is mainly the gynecomastia. So if some jimba na lelo pelo, so you should check it. So what is there? Aldactone. Okay. Then you change to eplerenone. Because see, sometimes in our thing we should think whatever is available in the market. Okay. Don't think that okay, I will give eplerenone, and if we cannot buy at some village, then it will be the problem. So see the drugs which are available nearby. Okay. Another, in a beta blocker, there is always confusion. What should I start? So remember that, okay, heart failure, best one is the carvedilol because of the peripheral vasodilatation. Newer trials also shown bisoprolol, which is used widely. You can start with the 1.25 of the bisoprolol dose, or carvedilol 3.125 2 times. Okay, bisoprolol 1 time is okay, 24 hours it can cover. So this is the thing. Arni, as we are going to discuss, we can start with the 50 milligram half tablet and then gradually make it BD and then slowly increase the dose. Okay. So as we said, Arni is the one of the important treatment, and it has shown big survival benefit over the ACI inhibitor, so which is more than 20%. Okay. So as compared to the ACI, so overall all the studies as shown by the clinical randomized trial, so it has a 20% more benefit, and just in terms of our words, it prolongs your life by more than 2 years. So this is one of the important thing, and it's early initiation in the hospital is the best thing to treat these patients. So this is very important. So I saw many patients in Myanmar, and I really thank this drug to give them the new life. So when you start this drug, it causes reverse modeling. So I regularly do the echocardiogram because it is easily available for me. So when I see this patient echocardiogram frequently, within improvement start very soon. After 6 months, the EF has significantly improved. I need to reduce the dose of diuretics, patient's quality of the life is improved, and then the blood pressure goes in a J shape, so it goes up. So we can titrate the dose of Arni. So this is called reverse modeling. So in this you can find there is an increase in EF, ejection fraction, A count, FEBB below. So in our 30% Shilelo, so it goes to the 40%, and after 6 months it goes to 60%. So that is a really nice thing about this. Do you know how this happens, this EF increases? So it is mainly by the natriuretic peptide. Okay, it is neprilysin inhibitor, so which increase the natriuretic peptide, which is a good molecule for the improvement in heart. Also by the diuresis, it reduces the stress on the heart so that your EF slowly increases. So that is how it got more benefit. And when we talk about the Arni and MRA, don't worry about that, because Arni versus ACI, Valsartan is the ARV which is similar. So it is not an isolated product. It is a combination of ARV and the Arni, neprilysin inhibitor. So we are not taking out the benefit of ARV. So now main challenge when it comes is when patient has the mild renal dysfunction. Okay, Chauka anere means we are worried. Okay, 1.6, what to do? See, up to 2.5, don't worry about the creatinine. Only thing is if it is 1.6, so we divide mainly the EGFR. Nobody calculates most of the time, but we can see that EGFR more than 90 normal. 60 to 90 is mild renal dysfunction. 30 to 60 is moderate, and below 30 is severe impairment. So just remember 60, 30 and less than 30. So up to stage 3B means, as Prof said, it is more than, if it is EGFR more than 25%, you can use all the drugs. ARNI, SGLT2 inhibitors, MRA, and the beta blockers. But after that, when the EGFR falls below 30, in gross, if the creatinine is more than 3.5, just remember, because what is practical is more important. So creatinine more than 3.5, be cautious about using the ARNI. You can use sometimes SGLT2 inhibitors, but if you are using ARNI, monitor the creatinine and potassium weekly so that you know if it is going worsening, please withhold or reduce the dose and reintroduce later. Okay, so creatinine 3.5 you take as a limit to be more cautious. 2.5 you can start with very low dose along with the SGLT inhibitors, because main worry about ARNI is sometimes about the potassium. Okay, so as I shown in this lower slide here, this one at the lower, here we see the creatinine 2.5 and potassium 5, no need to change about the dose of ARNI, you can continue. But if it is going up to 3.5, you reduce the dose of the ARNI. But when it is going more than 3.5, stop the ARNI, re-evaluate the things, wait for the patient kidney to improve. You can give some renal supplement, or you would see the causes, what it is worsening. Sometimes patients, most of the common cause, as I see in clinical practice, is taking NSAIDs. Okay, they go for toothache, the physician, dentist give them diclofenac or ibuprofen. Do nala, they take over-the-counter medication. So this is actually gift when there is a knee pain. These patients have the heart issues. So this is combination. So we should guide the patient that these two, ibuprofen and diclofenac or celecoxib, should be used very cautiously. They can use the paracetamol or tramadol for the pain rather than using these things. So that is how you think in cases with the renal dysfunction. So when there is a multi-morbid patient, so when the patient is having the heart failure with the ischemic cardiomyopathy, so it is like in the patient, he's a post-CABG and then EF is around 30-40%, potassium is 5, creatinine is around 1.7 or 8. So in these cases, and the blood pressure is 140/88. So we need to control the blood pressure also. So when the patient is having, we know that target blood pressure as per European and American Cardiology Society for the patient with the diabetes and hypertension is less than 130. So in these cases, with the reduced ejection fraction, with this type of blood pressure, we can treat with the ARNI. ARNI has a good effect on the blood pressure also in these cases. So we should start with the ARNI along these cases, but recheck the potassium and creatinine at the day 7 or day 3. You can start at the day 4 if it is in the hospital, or day 7, 1 week, call them back, check the potassium, creatinine, and adjust the dose of the blood pressure medicine ARNI, and then titrate every 2 weeks. First it will be 7 days, then 2 weeks, and then month, and then 2 months. So this is the best way. 7 days, then after that 2 weeks, 1 month, and then every month for 2 months, and then every 2 months. Once the renal status is stable, as per my experience, it doesn't change for 1 year. So most of the time you can adjust. At the 2 months, most of the drugs are adjusted. So blood pressure in heart failure management prevention. So as I show in the slide, if the heart failure, if the EF is normal, you just follow the normal guideline directed medical therapy for the hypertension, which is A, B, C, D. ARB, calcium channel blockers, beta blockers, and diuretics. If it is not controlled, then you go for the alpha blockers or hydralazine. But in cases of the heart failure, so many people ask, sir, the blood pressure of the patient is 100, because heart failure patient has not much blood pressure. It's borderline. 110, 60 or 70. Autaya pressure ma semo pune, no? So this is more worry. Diastolic is low. So diastolic low in old age is very common. So above 70, your blood pressure of diastolic, most of the people will have 60 or 50. So maybe because of aortic regurgitations or sometimes because of the elasticity is lost. So many pressure people ask me, sir, diastolic low, how I can titrate? You worry about systolic after the 70, don't worry about the diastolic. So that is more important. And once you start putting in the dilated cardiomyopathy cases, the ARNI, so if the patient is asymptomatic and the blood pressure is above 90, just continue to add. So 25 start, make it 25 BD, and then gradually you can increase. Okay, and add the other 4 pillars of the heart failure along with this. See, one thing is in these hypotension cases, wherever you can, if you cannot use the beta blocker, use the ivabradine, but try to add ARNI, then ivabradine, and then go with the SGLT inhibitors and the MRAs. Okay, so that is one of the things, and reducing the dose of diuretics. So that is one thing you can do. So this is the pictorial representation where you can see the it's a normal heart with the preserved ejection fraction. You use the CCBs and the ARBs. But in cases with the reduced ejection fraction, you plan to go with the ARNI, add spironolactones, and then doxazocin is the alpha blocker. It can also be used in the patient with the heart failure. Okay, so like many peoples with the alpha blockers we use in the prostate, so it is also can be used in these cases with the heart failure having the high blood pressure. So as I told, so this might not be new, but just repeating why neprilysin inhibitors are important. They increases the natriuretic peptides, which causes the vasodilatation, had a diuretic effect, inhibition of the sympathetic nervous activity. Okay, so this causes the reduction in the blood pressure and the improvement in the heart rate. And the ARBs, which are in a combination, also causes the inhibition of vasoconstriction. So this combination, ARB and neprilysin, is effective for the heart failure as well as the blood pressure. Okay. So now Dr. Dong already pressed on that, but I will just go brief on the hyperkalemia, when to treat and when not to treat, just to repeat. So when the patients are having the CKD, diabetes, heart failure, and the age more than 65, so these have high risk of having the hyperkalemia. When the patients are on ACI, MRA. So ACI, MRA can cause the hyperkalemia, but when you add the SGLT2 inhibitors, so it helps to reduce the risk of hyperkalemia. Okay, and associated therapy, the beta blockers, that can also lead to the hyperkalemia. So here patients like too much banana. So mapyodi salela. So that is the first question when the potassium is high. Okay. So siam mapyodi chaite nidai sale. So nene shole. Then also this. So this is common cause rather than going too much detail. So and also the coconut water. Ono ye. So these are the two things you ask patient. You can manage most of the potassium at this level. So this, if they stop to, you're okay. Second, then if the potassium is less than 3, IV replacement, if the patient is okay. Otherwise, we have the Slow-K or NPOT tablet. You can give the tablet and monitor the potassium. And so 3 to 5 you can manage with the oral supplementation of the potassium tablet. 3.5 to 5 is the okay. So at that time you can adjust the dose of MRA. So this is the good time, and keep the target level 4 to 5 if the 4 pillars are achieved. If it is increasing or decreasing, first try to adjust the MRA dose, and then you can diet modification and MRA dose, so you can adjust the potassium. But if it is more than some patients, see it is not about all the drugs. It is about the kidney of the patient. Some patients are good at the excretion of potassium, some are not. So every patient may have the variable dose. So rather than adjusting other three, you try to play in MRA dose. Like aldactone, you can make it 25, 50 or 12.5. So that will help you to guide potassium more practically rather than disturbing the other drugs. Okay. So if potassium is very high, more than 6, so we usually, one is initially the potassium binders. So these are not available with us, but we have Kellogg sachet, which is a calcium polyestrinate. They can put into the half glass of water, and then they can take twice a day. So it binds the potassium, sodium potassium exchange channel, and can reduce the potassium from the body. Okay. So this is, if it is more than 6.5, then you admit him. And then we have the glucose insulin regimen, astatine, and the diuretics, loop diuretics. That will help for if it is resistant, then dialysis, but it is very rarely. So monitoring is very important, okay? So as we discussed, the strong heart failure trials shows that we have to be very aggressive in starting the guideline-directed medical therapy. So clinically, you should start all the 4 drugs. Don't worry too much about the things. If you are clinically, things are okay, and if you are sure that, okay, patient is having heart failure, you start all the 4 drugs. So key initiation timing. So as we already know that we have to start all these 4 drugs, and we had discussed this in the last session also with Dr. Dong, so I will not go on that. So if you see all the 3 cases, here during the first cases, I said it is like a most common form of the heart failure, where like a 44-year male came with the non-ischemic cardiomyopathy. You start with this all 4 guideline-directed medical therapy, it will help. In case 2, we see there was a mild renal dysfunction. So you need to do the potassium monitoring at the 7 days, 14 days, and 1 month. And once you are adjusted, you can stop it. And in the case 3, you can, as per the blood pressure, if it is high, more than 140, you can titrate the dose of ARNI to 50 BD. Though if the blood pressure is low, you should not hesitate to start the ARNI. At the low blood pressure, you also start the ARNI with the low dose of 25 milligrams and titrate. If the some patients are there who can tolerate up to 70 or 80. Their systolic blood pressure is 80, but they can tolerate the ARNI. So don't take away the benefit of ARNI, although the pressure is low, if the patient can tolerate it. So take-home message is the early initiation of all 4 pillars to reduce the mortality. Ischemic cardiomyopathy and CKD prefer ARBs over ARNI and add the SGLT2, and MRA only if potassium less than 5. Okay, potassium is the gatekeeper of the RAS therapy. Monitor at 1 week after the initiation of the dose. Use potassium binders if the potassium is high. Target the BP less than 130 by 80 for the persons who have the hypertensions. For CKD patients, we should always think about if the eGFR is less than 30, we should be cautious. And echo is a very important thing. After the initial diagnosis, we should repeat the echo after 3 months, full echo. And some cases where if you feel there is a need of intracardiac defibrillator or the ICD, we should wait at least for 40 days post AMI to see whether the EF improves with the medicines. Thank you all for patience listening.
Thank you, Praveen, for your very interesting and very comprehensive talk regarding the heart failure cases and your management in the real world. Now we are having a special program before starting our Q&A sections, and after the event we'll be come up to the stage for the Q&A sections. Shall we give applause for the Praveen for his good talk? Now I'm going to give the master of ceremony to proceed your event.
Dear respected guests, we will now proceed to the official inauguration ceremony for Sakuban. May I kindly invite our respected chairperson, speakers, country manager to join the inauguration ceremony on the stage. May I kindly invite our respected chairperson, speakers, and country manager to join the inauguration ceremony on the stage. Let's celebrate this moment together. May I count 3, 2, 1 for you. So. 3, 2, 1. Thank you, Professor. Thank you, distinguished guests. Thank you very much for all your participation. Now, we will continue with a short product presentation by Hetero team. In today's cardiovascular portfolio, we would like to highlight Sakuban, an important option in heart failure management. May I invite the representative from Hetero Myanmar, Product Executive Ms. Winsumo, to proceed with the presentation.
Joy လာကြတယ်။ပမောက္ခဆရာကြီးများနဲ့တကွဆရာဆရာမအပေါင်းကိုမင်္ဂလာပါလို့နှုတ်ခွန်းဆက်တာပါတယ်။ကျွန်မကတော့ Hetero Labs Limited မြန်မာမှာ Product Executive ဝင်းစုံမော်မဲဖြစ်ပါတယ်။ဒီနေ့ Product Presentation လေးကိုကျွန်မတို့ရဲ့ Hetero Company Profile လေးနဲ့စတင်ပါတယ်။ Hetero ဆိုလို့ရှိရင် Global Market Pharma Market Industry ထဲမှာရှိနေတာနှစ်ပေါင်း30ကျော်ကြာမြင့်ခဲ့ပြီပဲဖြစ်ပါတယ်။ အဓိကအားဖြင့်ဆေးဝါးကုန်ကြမ်းတွေဖြစ်တဲ့ active pharmaceutical ingredients, finished dosing formulation နဲ့ biosimilar products တွေကို manufacturing facility 36ခုနဲ့ထုတ်လုပ်ပေးနေတဲ့ company တစ်ခုလည်းဖြစ်ပါတယ်။ဒါအပြင် Hetero မှာ global employee အနေနဲ့ employee ပေါင်း3000ကျော်နဲ့လည်ပတ်နေတဲ့ organization တစ်ခုလည်းဖြစ်ပါတယ်။အဓိကအားဖြင့်ကျမတို့ရဲ့ Hetero company မှာဆိုလို့ရှိရင် world class research and development center 6ခုနဲ့လည်ပတ်နေပြီးတော့ scientist ပေါင်း2000ကျော်က research and development clinical trial များကိုပြုလုပ်ရရှိပါတယ်။ကမ္ဘာအခုဆိုလို့ရှိရင်ကမ္ဘာနိုင်ငံပေါင်း145နိုင်ငံမှာကျမတို့ရဲ့ Hetero branch office တွေတည်ရှိပြီးတော့ main office ကတော့အိန္ဒိယနိုင်ငံ Hyderabad မှာပဲတည်ရှိပါတယ်။ကျမတို့ရဲ့ manufacturing facility တွေကတစ်ခုဖြစ်တဲ့ဈေးဝကုန်ကြမ်းဖြစ်တဲ့ active pharmaceutical ingredient များကို product ပေါင်း450နဲ့အထက်ထုတ်လုပ်ရရှိပြီးတော့ global pharma leaders များနဲ့လည်း partnership အနေနဲ့တည်ရှိပါတယ်ရှင်။ဒါအပြင် globally approved generic များကိုလည်း manufacturing facility စက်ရုံပေါင်း23ခုမှထုတ်လုပ်ရရှိပါတယ်။ဒါအပြင် cancer care management အတွက်လည်းကျမတို့ Hetero မှာဆိုလို့ရှိရင် oncology product များကို manufacture လုပ်ရရှိပါတယ်။ Hetero ရဲ့ pioneer ဖြစ်တဲ့ affordable treatment များကတော့ HIV/AIDS, hepatitis C, bird flu, swine flu နဲ့ COVID-19 products များကိုအဓိကထုတ်လုပ်ရရှိပါတယ်။ global အဆက်အရကြည့်မယ်ဆိုလို့ရှိရင်လည်းကျမတို့ရဲ့ Hetero က global pharma industry မှာတည်ရှိနေတာ1998ခုနှစ်ကတည်းကဖြစ်ပါတယ်။ကမ္ဘာမှာရှိတဲ့ HIV/AIDS patient တွေရဲ့ 40% ကကျမတို့ Hetero ကထုတ်လုပ်တဲ့ ARV treatment များကိုခံယူလျက်ရှိပါတယ်။အခုဆိုလို့ရှိရင်ကျမတို့ဒီ ARV product တွေအပြင် hepatitis treatment များကိုလည်း expand လုပ်လျက်ရှိပါတယ်။ global reach အနေနဲ့ကြည့်မယ်ဆိုလို့ရှိရင်တော့ကမ္ဘာနိုင်ငံပေါင်း120အထက်မှာကျမတို့ရဲ့ Hetero ရဲ့ product များကိုယုံကြည်စိတ်ချစွာအသုံးပြုလျက်ရှိပါတယ်။ဒါအပြင် Hetero မှာ world class research and development center 6ခုရှိတဲ့အတွက်အဓိကအားဖြင့်တော့ neurology, diabetes, cardiovascular disease, hepatitis, ophthalmology, hematology နဲ့ autoimmune disorder စတဲ့အဓိက therapeutic portfolio နဲ့ဆိုင်တဲ့ products များကို research and development များပြုလုပ်လျက်ရှိပါတယ်ရှင်။ အခုအဓိက presentation လေးအနေနဲ့ကတော့ကျမတို့ဒီ world data တွေအရကမ္ဘာ patient ရဲ့64 million သော patient တွေက heart failure ကိုခံစားနေရပါတယ်။ဒါအပြင် mortality risk မြင့်တာတွေ hospitalization rate မြင့်တာတွေနဲ့ quality of life ကိုထိခိုက်တာတွေစတဲ့အချက်တွေက heart failure ရဲ့အဓိက main challenge အနေနဲ့လည်းတည်ရှိပါတယ်။ဒါကြောင့်မို့လို့ heart failure ခံစားနေရတဲ့ patient တွေအတွက်သူတို့ရဲ့ heart function တွေကို restore ပြန်ဖြစ်ဖို့cardiovascular risk တွေကို short ချဖို့နဲ့ survival rate တွေကို improve ဖြစ်ဖို့အတွက်ဆိုရင်တော့ကျမတို့ hetero မှာ circulatory နဲ့ valsartan combination ဖြစ်တဲ့ circuvan ကိုအခုမြန်မာနိုင်ငံရဲ့ market ထဲမှာ available ဖြစ်နေပြီပဲဖြစ်ပါတယ်။ဆရာတို့မတို့အနေနဲ့ start early state ahead ဆိုတဲ့အတိုင်းပဲဆရာတို့မတို့ရဲ့ heart failure patient တွေမှာ circuvan ကို prescribe လုပ်လိုက်မယ်ဆိုလို့ရှိရင် heart failure ကြောင့်မို့လို့ဆေးရုံတက်ရတဲ့ hospitalization rate တွေ mortality rate တွေကိုတိတိတတ်တာ short ချပေးပြီးတော့ patient တွေရဲ့ quality of life ကို improve ဖြစ်အောင်ဆရာတို့မတို့ကကူညီပေးနိုင်မှာပဲဖြစ်ပါတယ်။ဒီ paradigm HF study ကကြည့်မယ်ဆိုလို့ရှိရင်လည်းကျမတို့ဒီ circulatory valsartan combination ကတခြားသောဒီ ACE inhibitor တွေနဲ့ရှင်းလိုက်မယ်ဆိုလို့ရှိရင် heart failure ကြောင့်ဖြစ်စေတဲ့ CV death တွေနဲ့ hospitalization rate ကို 20% အထိပို့ပြီးတော့ short ချပေးတာကိုတွေ့ရပါတယ်။ဒါအပြင် pioneer HF study ကကြည့်မယ်ဆိုလို့ရှိရင်လည်းဆရာတို့မတို့အနေနဲ့ circulatory valsartan combination ကို early initiation အနေနဲ့ပေးထားမယ်ဆိုလို့ရှိရင်ဒီ mortality risk တွေ heart failure ကြောင့် rehospitalization risk တွေကိုတိတိတတ်တာ short ချပေးတာကိုတွေ့ရပါတယ်။နောက်ထပ် proven study တစ်ခုဖြစ်တဲ့ proof HF trial ရကြည့်မယ်ဆိုလို့ရှိရင်လည်းဆရာတို့မတို့အနေနဲ့ circulatory နဲ့ valsartan combination ကို 12 months of treatment ပေးပြီးတဲ့အခါမှာ patient တွေရဲ့ heart ရဲ့ function တွေကပိုပြီးတော့ improve ဖြစ်လာတာကိုတွေ့ရပါတယ်။ဒါကြောင့်မို့လို့ဆရာတို့ဆရာမတို့အနေနဲ့patient heart failure patient တွေရဲ့ heart function တွေ improvement ဖြစ်စေဖို့အတွက် heart failure symptom တွေ control လုပ်ဖို့အတွက်ဒါအပြင် patient တွေရဲ့ quality of life ကိုပို့ပြီးတော့ improve ဖြစ်စေဖို့အတွက်ဆိုရင် circulatory နဲ့ valsartan combination ဖြစ်တဲ့ hetero ရဲ့ circuvan ဆိုတဲ့ product လေးကို prescribe ဖို့အတွက်လည်း request လုပ်ချင်ပါတယ်။အခုဆိုလို့ရှိရင်ဆရာတို့မတို့အနေနဲ့ circuvan နဲ့ circuvan မှာ prescribe လုပ်နိုင်မယ်ဆိုလို့ရှိရင်ဒီ dual mechanism of action ကြောင့်မို့လို့ heart failure ရဲ့ symptom တွေကို synergistic effect အနေနဲ့ patient တွေကို provide လုပ်ပေးနိုင်မှာပါ။ဒါအပြင် risk of hospitalization တွေ mortality risk တွေကိုလည်းတိတိတတ်တာ short ချပြီးတော့ patient တွေရဲ့ quality of life ကို improve ဖြစ်စေအောင်ဒါမက health care cost တွေကိုပါဆရာတို့အမတို့က short ချပေးနိုင်မှာပဲဖြစ်ပါတယ်။ dosage အနေနဲ့ကြည့်မယ်ဆိုလို့ရှိရင်လည်းကျမတို့ရဲ့ circuvan က dosage အပြင်50 100 200ဆိုပြီးတော့ stretch 3မျိုးနဲ့ available ဖြစ်ပါတယ်။ဒါကြောင့်မို့လို့ဆရာတို့အမတို့ရဲ့ patient saturation မှာမူတည်ပြီးတော့ဆရာတို့အမတို့ရဲ့ heart failure patient တိုင်းမှာ start early stay ahead ဆိုတဲ့အတိုင်းပဲ patient တွေရဲ့ quality of life ကို improve ဖြစ်အောင်ကူညီပေးနိုင်မှုအတွက်ကျမတို့ hetero ရဲ့ circuvan လေးကို prescribe လုပ်ပေးဖို့အတွက် request လုပ်ရင်းနဲ့ဒီနေ့ product presentation လေးကိုညီကုန်းချုပ်ချင်ပါတယ်။အားလုံးကိုကျေးဇူးတင်ပါတယ်ရှင်။
Thank you for your product presentation. Now, as we are going to start our Q&A section, may I invite both speakers to come up to the stage and to take a seat here. There are some questions, come up online, and now I'll start this Q&A section by allowing all of you to, ask the questions from here first. Now the floor is open for questions. Okay, Dr. Chowan, could you give him a microphone, please? Okay. Yeah, his question is, to start SGLT2 inhibitors and the heart failure management as a part of the 4 pillars, which one is most suitable, dapagliflozin or empagliflozin? Okay? Yeah, please.
Well, I think it's a tie. If you can start on any of the two. Yes. If you now take a look into the studies, it's really hard to compare because if you now look into the trials that involve your empagliflozin, They tried to look into the more serious ones. The dapagliflozin look into the more general population. But if you now take a look into all the data, it's a tie. Yeah, either of the two may do.
Okay, go on. Okay, and if you mention about the diuretics, we should not be confused with the, loop diuretics and potassium-sparing diuretics, which is MRE, which is an important component of the four pillars. But your question is, I understand, which one is most suitable, spironolactone or phenylenone? Okay, yeah, you're going to answer whoever it is. Yeah, it's okay, yeah.
So it's between the spironolactone, the MRA versus the non-steroidal MRA. Now, recently, the Americans have approved the use of your phenylenone for patients with HFpEF and HFmref, but not for HFref. Okay, so for HFref, we use either spironolactone or eplerenone, but not phenylenone. Yes.
Okay, thank you, Dr. John. This is a very important point. As we are going to classify the heart failure according to the left ventricular ejection fractions, 40% below 40 to 50 and above 50. And 40% above, that means MR, heart failure, MREF, and then, PEF. In such case, phenylenone is useful, but for the HFref, HFref, reduced ejection fraction less than 40%, the trial showed only spironolactone and eplerenone. Okay, this is very important point. If you misuse the drugs in the two different areas, that will not be beneficial as the trial shows.
If I may also add, when we use spironolactone or eplerenone in patients with heart failure, we're not using it as a diuretic. We're not using it as an antihypertensive. We're using it because we would like to take advantage of its ability to inhibit the RAA system, preventing too much aldosterone, and more importantly, for its anti-fibrotic effect, brought about by a huge inflammatory process brought about by heart failure. And we don't want fibrosis to happen. That's why Dr. Praveen has been mentioning about remodeling. If we don't take care of that, the heart muscle will go into scar formation, and that will lead to more bad events. So we want to prevent that, and your MRAs will take care of that, including also the other RAS inhibitors, because they're also good in preventing cardiac remodeling.
Thank you very much. It's quite clear. We should know the main aim and individual pathophysiological mechanisms of those drugs. And before, listening the questions from this audience, I'm going to ask one question which is important in the clinical practice. Many people, they have been using some of the drugs which is not mentioned in the guidelines, not necessarily guideline-mediated therapy in the heart failure. One question is, I want to know the role of coenzyme Q10 in the management of the heart failure. Let's hear what they are going to answer, please. Are you going to answer first?
Yeah. Exciting.
Yeah, very exciting.
So there are many different thoughts, but recent ESC guidelines has not mentioned that they are not beneficial. So they mentioned that it is not in the ABC, they are not beneficial, it comes into the C. But considering the people have a lot of thoughts about it is anti-inflammatory and antioxidant, and considering the other benefits, many people, at least in our country, use a lot, and overall there is a uptrend to use it. But definitely there are no guidelines from ACC or ESC to use CoQ10 in any of the heart disease from my side. But Dr. Dong, you can put your thoughts.
Well, I must admit, I use CoQ10, and let's add L-carnitine in patients with heart failure, although the guidelines do not mention it as part of the guideline-directed medical therapy, but it is just classified as a supplement. The reason behind that is in heart failure, your heart muscles are failing, they're weak. You need a lot of energy. So the physiology is, if you put CoQ10, it will provide more ATP production. So giving more food for the heart muscle. Also, with the use of L-carnitine, if I may add to the question, because these are very tempting questions, tempting drugs to use. In cardiomyopathy, not the ischemic type, okay, cardiomyopathy, the mitochondria are badly affected. And it's the mitochondria that produces the energy. Carnitine, L-carnitine is the one that can provide fuel to the failing mitochondria. So there are studies that also prove your CoQ10 and your L-carnitine to be beneficial, although these trials are small. That's why they cannot be considered as hard evidence to be part of the guideline-directed medical therapy for heart failure. So when do I use it? I will admit, in cases that I have put all four together and I have nothing else to add, the patient cannot afford all the other drugs, all the other interventions that Dr. Praveen can do. Aside from praying to God, I give these supplements. So that's an admission. It may not be in the guidelines, but at least I'm hoping and praying that somehow the supplements, they're considered safe. Although not proven to be very beneficial, it might, it might give some benefit. And then anecdotal information. In patients that I have used this one, I have seen great improvement. Okay, ejection fraction has increased, functional capacity has increased, but then again, these are just anecdotal. My personal experiences, my personal biases, like I use this in my mom, in my mother, who was diabetic, who was on angiography, non-obstructive. I've managed everything, the sugar, the kidney, boarding towards dialysis, and I couldn't add any more because there was nothing else to do. So, okay, came in your CoQ10 and your L-carnitine. My mother went to live 10 more years, longer than I have expected. So that's just one of the anecdotal stories that I have. But of course, it's not really in the guidelines. That's a disclaimer, okay? Just to suffice you with your query on the use of these supplements. But they're not really generally recommended. So that's a disclaimer.
No, that's very good point actually. So when we add IPDHA, CoQ10 and L-carnitine not only cardiac muscle but general benefits for our body muscles. It helps to generate the ATPs at the mitochondrial level, and it is many of the old cardiologists, not old but all cardiologists or electrophysiologists, they use L-carnitine in the cardiomyopathies. So now it is generally used. But if the patient has a well-being of appetite and their sleep improves, so that is an added benefit with the CoQ10 and other things. Another thing, when you are giving just to add to this thing, when you are giving this diuretics, so what common thing we appreciate things is there, you lost many of the your routine multivitamins, B1, B6 and B12. So that is and magnesium. So therefore these patients mainly complain, chotete, muscle cramps. So this is a very common thing. So I think these patients will really benefited with some additional B1, B6 supplement and magnesium, which is one of the very important and crucial element in the body, which regulates the cardiac rhythm as well as our sleep and our muscle things. So the chotete magnesium will be helpful, and it gives you the additional benefit for the cardiac rhythm stability as well as your sleep. So these are the micronutrients you should give in the patients where you are using high dose of diuretics and multiple drugs for treating the heart failure.
Agree, because one area that we tend to neglect also, aside from the mental, psychosocial and everything that I've mentioned earlier, is nutrition. Because if a patient has heart failure, there are a lot of food restrictions, right? Our patients tend to forgo meat. They go vegetarian. And that's where the micronutrient deficiency comes in. So I think we should also give, I agree with Dr. Praveen, we should give focus also on the micronutrition.
Thank you very much for this discussion, and I'm going to take this opportunity to talk to the audience that whenever you check the prescription given to the patients, majority of the drugs should be guideline-directed medical therapy. Whenever you check the medicines, 50% of patients, according to the guidelines and research evidence, you give it. But in addition to that, sometimes I've seen, so many patients receiving multiple placebos, 50% of them. Especially in the developing countries like us, we should save as much as drugs for the patients, as much as money for the patients. And then one proverb says in the past, which is very simple, the best physician gave the least medicines. Actually, we should rely upon the evidence-based and then guideline-based. I just like to remind that. But as Dr. Don said, sometimes if you don't have anything to do, but this drug is not strongly evidence-based, but for the satisfaction of the patients, you can prescribe. But it should be minimal rather than majority, okay? All right, another question is, during titrating the dose of the drugs, do we need to check edema of the lower limbs? Definitely, we need to. And Dr. Praveen highlighted that we started with the physical examinations and good physical, history taking and good physical examinations, including lower limb edema. And then after that, along with the 4 pillars, we have been using diuretics, strong diuretics like furosemide. We need to check the lower limb edema. If so, what we should do for further management, that's adjustment of the diuretics according to the edema level and presence of the signs, symptoms of pulmonary edema like, orthopnea, etc. This is okay, simple. But second question is, should we do blood test after all 4 drugs? I think both speakers highlighted to monitor the potassium and then renal function like creatinine. We need to check. But how frequent, how often should we check? Please, I think they have already, mentioned about that. And could you remind all of them, please? How frequent should you check?
Probably Dr.
Yes,
Praveen.
please.
After the initial starting of the drugs, you should call the patient after the 1 week so that you should check the creatinine, sodium, potassium, UNE, and NT-proBNP. And after that, you recommend, I usually follow after the 2 weeks. After the first visit, 0, 7, 21. And once at the 21, you adjusted and you think that creatinine and potassium is okay. And then every month, and then every 2 months. So like that I follow. 0, 3, 0, 7, 21, and then every monthly. So this is my
Similar. Because we also have to consider the convenience of patients following up with us. And if they're still in the acute phases or in the phase that we are still up titrating, it's very important for us to monitor all of this. But once we see the trend that they're stable, and then that's a time that I don't want to see the patient every month. For acute heart failure patients and who are now stable, I would like to see them maybe every 3 months if they're asymptomatic. In that case, they don't get to see you much. Okay? Because I think the issue here is about the diuretic. The goal of managing heart failure is they will use less of your diuretics, of your loop diuretics. Because if they still use diuretics, that means to say we're not doing our best. We're trying to get rid them off the diuretics. So it's just going to be the basic for and other medications needed.
Thank you. And another question is, majority of the heart failure patients, they are having the intercurrent illnesses like a chest infection and acute diarrhea from time to time. That's why when we are managing the patient with the heart failure, we have to consider the management of the comorbidities and management of the intercurrent, conditions which can precipitate the heart failure. One question is, if a heart failure patient developed chest infection and dyspnea, and heart failure patient develop acute diarrhea and pressure instability, how do we adjust the management? This relatively simple, but it's a common problem. And could you answer first, or Praveen, whoever it is?
Yeah, very good question. Very practical thing in this. Actually, when the patients get the acute diarrhea, they usually have the hypotension. So at that time, I think, so means I usually do is I withhold sometimes the dose of the hernia and diuretics because they are already dehydrated and kidneys are compromised. And once the acute things are settled, we restart with the gradual thing. So that is one thing I do.
Right, agree. It might be prudent to withhold some of the drugs that will endanger the kidney in particular. So check on your kidneys and your electrolytes. And when it goes to blood pressure, depends on the blood pressure, depends on the dehydration. If it's just, mild to no dehydration at all, I think there's no need. But if it's moderate dehydration or greater than that, and it's prudent for us to withhold some of the drugs that bring down the BP and compromise renal function, your ARNI included.
Thank you. I'm going to ask one important question because in today's meeting, we've been talking about the, heart failure with reduced ejection fraction. That should be determined by the transthoracic echocardiogram. Currently in Myanmar situations and, the remote areas, very hard to reach areas. Many people from that area, it's difficult to come up to the tertiary hospitals and to the cardiologist to have this echocardiogram to define the degree of the heart failure. We cannot know who is having the HFrEF or who is having the HFpEF. In such situations, remote, area, if they have a, for example, device like an echocardiogram, can they do there by trained person, not necessarily cardiologists or maybe medical officers? They can send a video clip to the cardiologist or radiologist to define that who is having the HFrEF or HFpEF. And what do you think? In your country, Philippines, and in your country, India, how do they manage, in the areas where it's difficult to get the echocardiogram? Please.
Thank you for that wonderful question. It's a very third world country question problem, all right? In my country, in areas that are really difficult to reach, what we do now is there are doctors in those areas that are enterprising. They build diagnostic centers, even just to the echo, even if they're not cardiologists. So what they do is, with the advancement in technology, they can just send the clips to doctors in the metropolis. So that's one way. And now, lucky for us in the Philippines, our government is trying to expand its healthcare to the remotest of areas. So we're now having national heart centers in the different regions. So we were in an era that it was really difficult to deliver healthcare. But with the present administration, not really praising the administration right now, but they're doing their best. And I think that's how we can do it. But sometimes I also admit there are areas that they don't really have 2D echo. I just play it by ear. If the patient symptoms, if they are orthopnic, that would mean that really the heart's ejection fraction is really low. If they are symptomatic with just simple movements, definitely the ejection fraction would be less than 30%. Now, over time, we have seen heart failure patients whose ejection fraction can be defined as mid-range, right? But they don't have any symptoms at all. But if they are symptomatic with simple movements, I bet everything in my body, the ejection fraction is less than 30%. And even without the 2D echo, because we don't have 2D echo in those areas, then it is with the confidence that I can start. Yeah, the 4. Yeah, I mean, better giving something than nothing at all.
Yeah, thank you very much. What about Indian situations, and what's your opinion for that, Dr. Praveen?
Yeah, India has a little bit better means we have the echocardiography centers are there, and we have the echo technicians which are doing the echoes at the periphery. and it is signed by the cardiologist, or they are seen by the videos are seen by the cardiologist. And some we have short training courses for the radiologist for the echocardiogram, so that they can at least do the basic echocardiogram, which will be useful for the patient. And even we are developing that for the intensivist. And some physicians also get the special training for the echocardiography course, and then they can give the basic provisional report for the echocardiography, so that these cases which are moving, which are missing, we can cover it. So I think so ECG, echo, blood pressure and sugar, these are the major things which everybody should be accessible in all the country, because they are non-invasive. Maybe with the time they will be less costly, but can prevent a lot of the morbidity burden over the countries.
Thank you very much. Another question from online is that the patient is having a CKD stage 4. Can I get some insight into titration of the diuretics? Or, I think it should be 4 pillars drugs titration rather than diuretics titrations. I think speakers also mentioned about how to titrate the drugs according to the renal functions. Also, Dr. Praveen gave the one case having the hypertension, diabetes, and CKD stage, and how to titrate the drugs, especially MRA and then RNA and diuretics. I think it has already been included. Could you like to remind them?
Right. So CKD patient, diabetic at that. So your drugs will still benefit them, but we have to be careful with the level. Again, I think Dr. Praveen and I have mentioned that there are certain renal function that we cannot really start our drugs on. But if they have been on these drugs before, their renal function became worse, it still indicated that we continue. They can still get the benefits. But if they're nearing towards the low range, like 20, and it's your first time to put these drugs on, then have a second thought and a third thought. They might not benefit. They might not get any benefit. So it would be really best to begin to start these drugs early on before they go to stage 4, before they go to stage 5. So start early so that you can stay ahead. That's what this drug is all about.
Thank you very much. Another question is interesting. Old person mean like us, isn't it? Yeah. With medical checkup nowadays, it's a common doing the medical checkup. Actually presented by the younger populations, sons and daughters, nephews and nieces, to do the medical checkup. Especially medical centers gave a special discount in special seasons. They do the checkup and found to have a low ejection fraction of the left ventricle, 35%. But his normal, pressure is normal. And what is the next step? That means patients not probably having the symptoms of the heart failure, but only low ejection fraction. We should remember the stage A, B, C, D according to the structure and functional abnormalities. Please, could you, both of you, remind what is stage A, B, C, D, and how can you manage such patients, without having gross symptoms of the heart failure?
My Viva question. So it's like so stage A where there is only the risk factors are there. Okay. When the stage B there is a structurally damaged heart. Stage C where there are the symptoms are NYHA class 3, and stage 4 is the end stage heart failure. So stage B and D are the established heart diseases. So at that time we need DCD. We need to treat. Though the patients are asymptomatic, we can check the NT-proBNP level, and still their ejection fraction is low. They need the GD guideline-directed medical therapy. May not be the because they are compensated. So there are called as compensated and decompensated in our when we say patient is admitted to the acute ADH, acute decompensated heart failure. So they might be stable in their walking, they have no symptoms, but as soon as they land up into some UTI or some pneumonia, or they get some heat stroke, or they take some mowing or onocausis, so they get the symptoms at that time. So when you take a little bit salt, so that is what precipitates the heart failure, then called the decompensation. So though they are asymptomatic, and when we find accidentally they came for the checkup, we should treat them with the 4 pillars and try to get them. So that is
Right. While there are cases that the ejection fraction is really low, and these people are really asymptomatic, no symptoms at all, but I would challenge you, you have to be more astute in taking the history, more so in older individuals, not really professor, he's still young, all right? Because older individuals tend to move less. So when you ask them, do you have difficulty in moving around? No. Because what they just do is from the bed to the bathroom or bed to the dining room. But you've never asked them if they ever climb up a flight of stairs, what would they feel? So for the younger colleagues here, you have to be more wise. You have to do some more, maybe some physical testing, like practical 6-minute walk test. You can ask them to climb a flight of stairs, do something more strenuous than their usual, just walking. We have to be more careful when we ask the history. And mind you, you will find that they will be symptomatic. At 30%, I doubt if they don't have any symptoms at all. They will adapt, they will move less. And they'll tell you, yeah, I'm fine. I'm fine sitting all day, right? Then they begin having bipedal edema, and then they have orthopnea because we have not managed them quite well. But again, even if they're asymptomatic, if their ejection fraction is classified as HFrEF, then treat accordingly. They will still reap the benefits of giving all the drugs that are recommended for HFrEF.
Thank you very much. Yes, the time is running short. I'm going to ask the last question, which is also very important. When we are treating the patient with the 4 pillars, in first place, either ARB or ACE inhibitors or ANI. That has been mentioned like that. And then after that, beta blockers, MRA, and SGLT2 inhibitors. There is no confusion for that. One question is here, can we give together with the ARB, ACE inhibitors plus ANI, which is going to be quite dangerous? Please could you give a last answer for that, either of you? Combination, Combining ARB, ACE inhibitors plus ANI.
No, triple combination is definitely not recommended. There were some studies.
Either ARB or ACE inhibitors. On top of that, should you add ANI?
ANI. ANI is actually we have the combination of valsartan and the sacubitril. So it is like because this combination came into, this is called ARNI. So it is already the ARB plus the neprilysin inhibitor. So on top of that, if the question is that you have to add ACE for that, so the answer is no from my side at least, because there were some trials they combined only ARB and ACE, so they had a high risk of the hyperkalemia. After that, they stop from the trial. So I think so. ARNI is a combination of, already there is a ARB, which is valsartan, and that was the only ARB which was found to be beneficial when using with the neprilysin inhibitor. So that is what when they do the trials. So this is a really wonderful combination. Still, I don't know why valsartan only, but other ARBs were not so beneficial as that of valsartan. So that was the thing during the trial.
So do not combine 2 RAAS inhibitors together. That was the on-target study lesson. They combined telmisartan and another ACE inhibitor. Patients had more hyperkalemia and they died more. So that concept has been abandoned long time ago. All right. So I think one final thing because nobody asked this one. If a HFrEF patient, the ejection fraction has improved tremendously, as in it went back to normal, we classify them as HFrEF with improved ejection fraction. Question is, should you discontinue all the 4 drugs or any of the drug? No. There are drugs that are meant to be forever. So continue, even if the ejection fraction has improved.
Yeah, that's very important, answer given by the Dr. On that when you look at the class recommendation, he highlighted the color of the class recommendations. In HFpEF, all are green, 1A, 1A, 1A. But in HFpEF and HFMRF, some of them become 2B. That is initial studying, drug therapy and heart failure. 2B may not be used straight away, but once a condition become improved from HFrEF to HFpEF, we should continue the same 4 pillars, which is very, very important. Thank you for pointing out that. Okay, now as time is running short, I'm going to give you the final message from this meeting. The first one is you have to you remember everybody, different classification, which is very up to date, is according to their LV ejection fraction, and then 4 pillars, which started, in the management of the heart failure from last ESC 2023, 23 and 24. After the introduction of the SGLT2 inhibitors, it became 4 pillars, which should be known by all of you. And when you are going to start, as the speakers highlighted, beta blockers and SGLT2 inhibitors should be the first, and after that, ANI should be at, and then MRE should be at. But the adding of the one drugs after another should be within 4 weeks. That means as soon as possible, within short period, and then you don't need to take 6 months for that. And while you're giving this such treatment, you have to monitor the patient's blood pressure, potassium level, and then renal functions. Those are very important. And then I think one important point, because as I listened, the one important lecture in Taipei recently last week, and Dr. Don chaired the sections, Nabivolol. It's the beta blockers are specified in the 4 pillars, carvedilol, bisoprolol, and metoprolol. But Nabivolol is on the way to be included in these 4 pillars. I'm not, advertising the Nabivolol, but as I listened this lecture, very nice lecture in Taipei. Now I'd like to thank, all the attendees here as well as online for your attending today's symposium, and I also like to thank, Hetro, Country Maria, and your team for supporting this event. Last but not the least, very renowned speakers one from Philippines and one from India, giving the very interesting, comprehensive lectures for all of us. Thank you very much, all.
Yeah, doctors and distinguished guests, we have one more exciting activity prepared for all